Hi, thank you for inviting me today. I was given the remit today to talk about UTIs, and UTIs are regarded as something that really isn't that important quite often, and something that's a quick fix. GPs often look on a patient presenting with an acute UTI as almost like a break, because just give a quick course of antibiotics, Bob's your uncle, nothing complex, but actually that's only part of the story, and I'm hoping to actually just touch on this today. We will only be able to touch on it briefly because we've only got a 20-minute slot. It is actually a fascinating area, and it is a hugely important area, as urinary tract infection is now the commonest presenting bacterial infection to healthcare. Just a little bit about myself. I'm actually a GP, but I was a scientist before I trained in medicine, and medical microbiology was my forte. Therefore, after I became a GP and did some extra postgraduate qualifications in women's health, it was a natural progression to become very interested in urogenital infections. And of course, UTIs are part and parcel of that, hence my involvement with Bladder Health UK over the years. I do have conflict of interest to mention in that I do also have a private clinic and also a private lab. So just moving on, let's just have a very brief recap, and I don't mean to insult your intelligence because I know you all know what a UTI is, but just to scoot through, we know that urinary tract infections present as painful urination, dysuria, burning, stinging, pain in the lower abdomen, often accompanied by frequency, urgency, dashing to get to the loo, sometimes even incontinence. Patients can feel quite unwell with these symptoms as well, systemic symptoms. Certainly, patients who have got more complex UTIs can also have constant pain and pain after urination. We know that it's an incredibly common ailment amongst women, and this is partly due to differences in anatomy, the fact that God gave women 3 centimeters of urethra, whereas blokes have got about 20. And unfortunately, there's also the very poor structural design that women have got a sewage works right next to a leisure centre with the urethra abutting right next to it. Now, we know that half of women, up to 60% of women actually will experience a UTI at some point in their life. And molecular analysis that we now have access to but don't commonly use does reveal that in the presence of discomfort associated with urination and also frequency, over 98% of those women will have bacteria as the root cause of their symptoms. We know that roughly 3% of patients who have persistently recurrent UTIs are so persistent that although it's not a true definition, we call it chronic UTI, will end up with these life-altering persistent symptoms. Now, in the UK, that equates to over 1 million women. So it's really not something to be as swept under the rug as it is currently, and this is why the work that Bladder Health UK do is so important. We've already mentioned how common this disease is, and we certainly know that it's common in the community, it's common in primary care, and it's incredibly common in secondary care. And of course, we mustn't disregard catheter-associated UTIs, which cause significant morbidity and healthcare costs. So let's talk more about recurrent and what we have called chronic UTI or persistently recurrent UTI, because we know that most acute UTIs are fairly standard treatment sortable. We know that there are 2 definitions for recurrent UTI, either 2 episodes within 6 months or 3 within 12 months. Most clinicians prefer to use the latter because 2 and 6 months can indicate a relapse of the original infection and not a de novo infection. We know that over 36% of women who have had one UTI will go on to experience a second within the 12 months. That figure rises in postmenopausal women. Looking at women over the age of 55, we see that over 53% of women will have this second occurrence. Once a woman has had 2 UTIs within a year, unfortunately, probability tells us that they will go on to further episodes. We know that over 2% of women suffer with persistently recurrent infections, life-altering infections. Now, I'm not being sexist. This does happen in guys as well, but women are predominantly affected by this condition. Now, what do we do? What do we do when patients present to us in the clinic with complaints of urinary symptoms? Well, quite often, the doctor, the nurse, will grab for the dipsticks, pop in a dipstick to do a chemical urine analysis. And yet, we know that up to half of dipsticks are negative, yet bacteria will grow in culture. And it is a common occurrence for the patients that present at our clinic to be telling us that they have popped to their general practice, seen a clinician there, and been told that despite their symptoms suggestive of a urinary tract infection, and indeed they felt it before so they can recognize it again, they've been told, no, dipstick says no, there's nothing wrong with you, off you pop, it's all in your head. Very undermining, really. Even the NICE guidelines embrace the fact that we should not be using dipsticks to diagnose UTIs. We should actually be using patient symptomatology to decide whether we should be using a course of empirical antibiotic treatment. Now, the guidance is very much centered around acute UTIs with a cursory mention of recurrent UTI. And acute UTI treatment, according to local and national guidelines, is 3 days of first-line antibiotics, usually nitrofurantoin, sometimes trimethoprim. The reason why trimethoprim has really fallen back from center stage is because of the rising rates of E. coli-mediated resistance. And of course, organisms such as Enterococcus are inherently resistant to antibiotics such as trimethoprim. Now, we do know that most key opinion leaders, and indeed most GPs who recurrently see patients with urinary tract infections, are aware that 3-day courses of antibiotics sometimes just don't cut the mustard, and that actually longer courses, 5 days and 7-day courses, tend to be more successful. Looking at what we do when we send these urines off to the laboratory, which indeed doesn't meet with what is advised in most local and national guidelines. We are advised to go ahead and treat initially without sending, but if we don't send to the laboratory, we often miss that golden window of opportunity to find out what the offending pathogen, the offending organism is, because if we hit the wrong antibiotic, and indeed even with nitrofurantoin, with its lesser degree of resistance compared to trimethoprim, if that poor patient is presenting with something such as a Proteus infection, which is still fairly common, or Morganella, or God forbid, Pseudomonas, they're actually going to be inherently resistant to nitrofurantoin. And we've missed that opportunity for testing them, for defining what would be the most appropriate. So as far as I'm concerned, samples should be sent to laboratories. It is best practice, certainly for a patient that is presenting more than once with a UTI. So once they get to the laboratory, what happens? Well, the majority of NHS labs use automated systems, robotized machinery to test the samples. A small aliquot, 1 microliter of urine, is taken out and popped through a flow cytometer analyzer to check and count the number of white blood cells, red blood cells, bladder lining cells, epithelial cells that is, and bacteria. There are certain criteria to actually decide whether this is a true infection or not. If there are less than 40 white blood cells per microliter, it will be deemed as insignificant. Likewise, a figure of 10,000 bacteria per mil or less is deemed as insignificant. Now, this is all based on the CAS criterion, and the CAS criterion was derived from a study back in 1957 on 88 pregnant women with kidney infections. So CAS really wanted to know, at what level does a kidney infection become dangerous to the pregnancy? At what level are we risking pregnancy loss? And that line was drawn in the sand. And that line in the sand was 100,000 organisms per milliliter of urine, 10 to the 5 per milliliter of urine. Anything under that was not significant in terms of significant disease for the woman. Anything above it was significant. In the annals of time, that insignificance has been translated into no infection. So women are quite often presenting back to their GPs being told, sorry, no infection. But actually there was infection, especially in a patient with a recurrence, because their bladder is hypersensitized. It's already lost its innate defense mechanisms. So it is reacting with inflammatory response at a much lower titer of bacteria per mil than 10 to the 5. And yet they are being told that actually the culture wasn't taken forward, that there was no significant growth. But no significant growth does not mean no growth. And that's if the patient even manages to get to the point where they're cultured. Quite often, they've been rejected right at the first hurdle because they didn't have the requisite number of pus cells, they didn't have the requisite number of bacteria, etc., etc. So there's a lot of hurdles to jump before you actually earn your treatment. And unfortunately, patients with recurrent disease or chronic disease find it even harder because they are reacting badly at very low levels of cells. And additionally, they are finding benefit from drinking loads of fluids because it's diluting that nasty acidic urine, which is hurting them. And so they are producing very weak samples, and these weak samples are not going through any calibration. If we were being scientific, we would be looking at the creatinine concentration of these urine samples and extrapolating the number of bacteria against that. But actually, a dark orange urine and a urine that looks almost like tap water are regarded exactly the same. But it stands to reason that those bugs are going to be far more spaced out if you've drunk a gallon of water than if you're dehydrated. We also see that 2 or more species of bacteria are generally regarded as mixed growth and put down to contamination. Yet we now know and have the evidence that patients with complicated recurrent disease normally have 2 or more species of bacteria coexisting. So we talked about the standard treatment for acute UTI, 3 days of trimethoprim or nitrofurantoin, and indeed this is successful in most acute cases, especially in younger patients, which is great. But even the study that this was taken from acknowledged that 5 to 10 days was far better at eradicating the bacteria from the urine. But based on the fact that antibiotics can cause side effects, and most women were symptomatically vastly improved after 3 days, they decided to recommend that 3-day courses be adhered to. But when you actually get into the finer detail of the study, you see that actually it was a fairly artificial environment that this study was carried out in, that it wasn't real life. It wasn't a woman who was struggling for days to get an appointment at the GP practice. These were women who were pre-counseled and literally had pill in the pocket to start the course of treatment as soon as their symptoms presented. So we know that our more complex cases are not served by the current guidelines. What can we do in terms of improving testing? Well, we know that there are different methods of testing. There is extended quantitative urine culture. This is what we do in my laboratory. Unfortunately, my laboratory is private because we are not protocoled within the NHS. Although the NHS has got the facilities to perform these tests, it just isn't resourced to do this, apart from in maybe very exceptional cases. We use criteria where we narrow down and look at lower levels than 10 to the 5 in terms of bacteria, and we also use broth extraction methods to look for very low levels of bacteria. There are also molecular methods such as PCR with next generation informatics, which can be used. However, these are not widely used, especially in the UK. Certainly they are in the States, but interpreting these results is a minefield because it shows up so many different organisms, and the extent of microbiological knowledge amongst clinicians is not currently sufficient to be reliably interpreting from these results. I myself did quite a lot of molecular in my science degree, and I still find it trying at times to interpret the molecular results. So there is a need to really study this and look to improving what we're doing. There's a very interesting study that was done in 2017 in Belgium, where they took 220 patients who were all symptomatic of UTI, and yet all had failed on standard cultures as per the CAS criterion. They also took a cohort of healthy controls. They were actually university students who'd never had a UTI, because we always expect 10% of the population to have bacteria present without symptoms, asymptomatic carriers. Very interestingly, this study revealed that with extended quantitative urine culture, such as the culture that we use in my private lab, that well over 60% of the patients who were culture negative yet symptomatic were positive for E. coli, and well over 90% of the patients who were symptomatic but culture negative on standard cultures were positive in terms of PCR molecular testing, proving irrefutably that we are not doing enough. We are not looking deep enough for the tricky to diagnose cases. So how do we treat these more complex cases? You know, it's difficult enough to diagnose them in the first place, and really the most reliable thing is the patient history. Treating them, well, we still need to use appropriate antibiotics, so appropriate testing is really pertinent. Antibiotic stewardship really needs to be adhered to, and scattergun approach of short courses of first-line antibiotics is really the worst thing you can do in terms of stewardship. The best thing you could do is find out exactly which antibiotic you use that is going to be effective and use it for the shortest time possible, but to deliver effective treatments rather than recurrent treatments. Because anyone in a lab will tell you that if you want to generate antibiotic resistance, what you want to do is go with suboptimal doses of antibiotics and put them in, take them out, put them in, take them out. So you go in with a longer course of full treatment dose, appropriate antibiotic, and then as the patient's symptoms melt away, you titrate the dose down, and then slide something else in, something such as methanamine hippurate, which is a fantastic non-antibiotic urinary antiseptic, or possibly even naturopathic measures. We commonly use naturopathic measures in our clinic, and these active polyphenols are absolutely fantastic. Active plant polyphenols have given us so many of the drugs that we use today in modern medicine. You know, it's moving from aspirin through to some of the chemotherapy agents, but plenty of antimicrobial compounds live in the plant world. And we can trap that and use that. And my next slide will actually show you this. But just before I move on to that, please don't underestimate lifestyle adaptations in combating this disease in patients with serious recurrence. Yes, it can be really boring to give up caffeine and coffee and be extra careful around times of sexual intercourse, pee before and after, make sure you're well hydrated, well lubricated. Make sure that you don't go sitting in hot tubs and jacuzzis, because they are dreadful for generating nasty UTIs, especially ones with Pseudomonas, because they love living in the jets. You know, careful lifestyle management can really improve things. There's details that you can get on this on quite a number of websites. So talking about the naturopathic agents, just to show you an example of a few of them, we've got some fantastic evidence these days for D-mannose, which is a naturally occurring plant sugar, which is not absorbed by human beings or animals at all, and it is excreted into the urine. It's a very small molecule, and it mimics the receptor that E. coli and probably Klebsiella binds onto on the bladder lining. So it's literally like rolling a sticky dough ball in flour. Although it doesn't kill the bacteria, it helps you pee them out. It stops them from binding to the bladder and setting up new rounds of infection. And it has been shown in some trials to be as efficacious as nitrofurantoin prophylaxis if taken properly. There are lots of other different things that patients take. You see a list of a few here: morinda, N-acetylcysteine, grapefruit seed extract, oil of oregano, high-strength garlic extract, ursi. And let's not forget patients' innate immune defenses, and making sure that your gut microbiome is healthy, especially if you've had repeated courses of antibiotics, is really essential. So I am always advocating good, high-strength, multi-strain probiotics, or taking kefir or doing the pair together. I personally will not prescribe antibiotics for my patients unless they will take probiotics at the same time. Going to the supermarket and buying Actimel just ain't going to cut it, because we're talking single species of bacteria and not even that higher level. So really save your money and go and buy it from a health food shop or off Amazon and get something that's highly recommended. Google's a great resource for that. So what other non-antibiotic lifestyle measures can we use that I'd already mentioned? Lifestyle measures. And it seems like it's really almost insulting your intelligence, but I'm sure you all know, we'll go over it again. So it's really important to encourage the patients who have recurrent UTI to cleanse after every bowel motion if they can. So get into a good bowel habit and rinse from front to back with a shower hose with warm water to rinse off any traces of fecal matter, which may not be visible but may be still adherent, because these little critters do climb forward. Especially in postmenopausal women, we so commonly see abnormal vaginal microbiomes where we have a paucity of estrogen not supporting the healthy lactobacilli, which keeps the vagina acidic and keeps the bad bugs at bay. And we get colonization with bowel flora. It's incredibly common to find E. coli, Enterococcus, Klebsiella, Proteus, etc. in postmenopausal vaginas. And of course, the urethra is right next door. So we're really waiting for this accident to happen. And this is partly why postmenopausal women suffer with this disease so much more. So it goes without saying that in fertile women with periods that changing towels regularly is important. Also, not using tampons can be seen to help, partly because of the bleach in tampons, lowering vaginal and bladder defenses. These white products are always bleached to gain their white colour, so that's worth bearing in mind. Drinking plenty of fluids, avoiding caffeine. I always tell my patients to avoid white wine as well. Purely experiential. I just see so many of them flaring up when they indulge on Prosecco and white wine, etc., etc. Don't know what's in it, but someone needs to do a study on it because it definitely happens. I try to advise the patients who have severely recurrent disease to be careful around chlorinated water, swimming pools, jacuzzis, hot tubs. We do see patients falling foul of this happening. Mechanism, who knows? Maybe it's ingress of water into the urethra. We certainly know that chlorinated water can cause irritation and maybe start a chain reaction. We've already mentioned care around times of sex, and the last but by no means least, especially for our menopausal and postmenopausal cohort, is topical vaginal estrogen. We do have some good evidence that a minimum of 6 weeks of topical vaginal estrogen, and we see an improvement in patients with recurrent UTI. There are plenty of different varieties available these days. It's one of the hormone replacement therapies that we haven't actually got a shortage at the moment, which is unusual.
and it really does provide benefit. We see some patients with recurrent UTI completely delivered out of their UTIs by using adequate doses of topical vaginal estrogen, and others who just get the occasional ones, completely eradicated. In the patients who are the worst of the worst, who have really chronic symptoms, we usually see a benefit as well. So it is so important, and that has now made it into the NICE guidelines, and it is commonly being recommended by urologists. So, in conclusion, we can say that UTI is an incredibly common disease, especially in adult women and postmenopausal women. We know there are a few treatment options that we can use, that there is a lack of evidence, and that we know that the complex cases, the recurrent and the chronic cases, really suffer from a lack of evidence, a lack of diagnostic options, and a lack of treatment options. And that is something which has been neglected for years and really needs to change. We know that there is need for more recognition, understanding to aid prevention and treatment. We need this not just amongst lay people, but also amongst healthcare professionals. We are now in the unfortunate position whereby the lay people, the expert patients who suffer with this condition, are actually becoming more knowledgeable around UTI than their clinicians that they consult with prescribing rights. We talked about needing further research and studies to aid diagnosis and treatment. Please, if you're ever asked, give your support towards it. And I mustn't underestimate the support organisations out there. Today, I'm speaking on behalf of Bladder Health UK, who have got an amazing national presence and are actually known overseas as well for the work that they do. We probably lead the world with BH UK in terms of support for these patients with more complex illness. But there are some other really good organisations, QTIC, which is a campaign for chronic UTI, and also Live UTI Free, which is an international forum, which is very, very good at raising awareness online. So please recommend these resources to your patients if you have patients that suffer with UTIs recurrently, because there is an absolute plethora of resources on their websites explaining how to get better testing, how to improve their lifestyles, how to get more accessible treatments than they currently have available in our standard NHS care.